morning, everybody. My name is Erin Braun. I'm a program coordinator over at Western New York Rural Area Health Education Center. We are in Warsaw, and the goal of our nonprofit is to promote health and health education in our rural communities. So thank you for joining us in week 3 of our Choosing Hope series. So the goal of our Choosing Hope series is to provide awareness and education on substance use disorder and opioid use disorder, the treatment and recovery methods, and the stigma that goes along with addiction. So we will be continuing every Tuesday in April for our Choosing Hope series. Next week, we will have Davina Moss King presenting at 12 next Tuesday. If you didn't sign up, you're still welcome to join using your original Zoom link. So just an overview, I'm going to have you stay on mute during the presentations, but you're welcome to unmute after the speakers finish and ask questions. We have 2 speakers speaking from 12 until 12:30, and then another speaker from 12:30 to 1. When you ask, if you have a question, you can ask it, or you can use our chat box. If you look at your toolbar, you can ask it. You can direct the question directly to a participant, or everyone can see it, or you can use a Q&A where just the panelists will see the question. So today we have Shantasia Bronson and Callie Loren from New York Matters presenting MAT, or Medicated Assisted Treatment, for our first half hour. They're from New York Matters. So Shantasia's from Buffalo, New York, and has a public health background. She's experienced working as a pediatric care coordinator for a local health home agency, and management experience working as a patient experience liaison at ECMC, and currently works as a program coordinator at New York Matters. Callie serves as the program manager for New York Matters and has a background in psychology. Callie has experience in the medical field, working as a patient care technician in an emergency department, as a nursing assistant, and as a research assistant in a clinical research program. So I'm going to go ahead and pass it over to them. And if you have any questions, we will ask after they finish speaking.
All right, great. Thank you so much. And thank you for having us today. And thank you everybody for being here on your lunch hour to hear a little bit about opioid use disorder in general, a little bit of an intro to medication-assisted treatment, and then also an introduction to the New York Matters program. So I will share my screen here and we will get started. Okay. So hello, everybody. My name is Kaylee Loughran. I am the program manager for New York Matters, and I'm here today with my colleague, Shay Bronson, and we're just going to kind of go through an introduction to the Matters program, but then also opioid use disorder and medication-assisted treatment in general. So a couple things that I wanted to just kind of to lay the groundwork for our presentation today, just a couple of things that we know about opioid use disorder to be true. So first and foremost, we know that opioid use disorder is a chronic disease and it needs to be treated as such. So opioid use disorder needs to be treated as diabetes or heart disease or cancer or any other severe life-threatening disease that affects our loved ones or ourselves. We also know that the treatment of opioid use disorder typically requires the use of medication, and we'll go into a little bit more depth on what type of medication specifically can actually treat opioid use disorder itself. And fortunately, we have a couple really good forms. And then lastly, unfortunately, another thing that we do know is that simply abstaining from use or abstinence-only treatment typically has very poor success rates. But again, we have some great treatment options that we're going to run through. So here's just a couple facts about opioid use disorder that we kind of wanted to lay the groundwork to our discussion today.
So we thought it might be helpful to share some opioid-related statistics, as opioid use disorder is very prevalent in the United States. So from 1999 to 2019, approximately 500,000 people have died from an overdose involving any opioid, including prescription and illicit opioids. In 2019, an estimated 10.1 million people aged 12 or older misused opioids in the past year. Nearly 92,000 people in the US have died from drug-involved overdoses in 2020, including illicit drugs and prescription opioids. About 136 people die every day from an opioid overdose. And then on the flip side, there has been a 4.1% decline in drug overdose deaths in the US from 2017 to 2018.
So we can think of opioid use disorder kind of as a cycle that can be very, very difficult to break. So somebody might use opioids that's going to trigger a sense of calm and pleasure in the brain. And then once that individual abstains from use, they're probably going to experience withdrawal symptoms if they actually do in fact have opioid use disorder. These withdrawal symptoms, there's a whole bunch of them: nausea, vomiting, but in the short of it, the patient is going to be very uncomfortable. They're going to experience extremely painful symptoms after abstaining from use. So in turn, they're going to start to crave to use again. They're going to have a strong desire to use opioids. And as you can see, that can just kind of trigger the cycle again. And breaking this cycle can be very, very difficult. So now we're going to turn to how do we actually diagnose an individual with opioid use disorder? And to do so, we're going to take a look at the DSM-5 criteria. So as you can see listed on the screen here are a whole bunch of different symptoms that a patient with opioid use disorder, or more generally substance use disorder, might have. So they might have to use larger amounts of a substance for a longer period of time in order to reach the same effect. They might give up activities that they used to previously enjoy in order to use. They might crave to use the substance. They might experience withdrawal when they abstain from use. They can have social or interpersonal problems related to their substance use. They might even neglect major roles to use, such as, family obligations or jobs or school or something to that effect. So the way that we're going to diagnose somebody with opioid use disorder is if they have at least 2 of these symptoms listed here on the screen within a 1-year time frame. And then we can go on to further define their disorder based on severity. We can define them as having mild, moderate, or severe opioid use disorder. And to do that, we're going to take a look at actually how many symptoms listed here on the screen that individual has.
So there are several different treatment options for treating patients with opioid use disorder. So whether that be counseling, psychiatry, or medication-assisted treatment, which we'll talk about in the next couple of slides. But currently, only about 20% of people with opioid use disorder are being treated for it. So as Keely mentioned previously, opioid use disorder, just like diabetes or other chronic conditions, is a chronic disease. And so it's important that patients, be treated for this as such. And so we're hopeful that in the near future, with increased education and awareness, that this number will increase.
So again, just to kind of refocus ourselves and bring it back to the couple of things that we laid out in the beginning of the presentation. We know that opioid use disorder is a chronic disease. It needs to be treated as such. And unfortunately, simply abstaining from use is not typically a very successful form of treatment. So the question kind of becomes, so how do we treat patients with opioid use disorder? And fortunately, we have a whole bunch of different treatment options that are very successful for patients. So as we kind of mentioned previously, chronic diseases typically require the use of medication to treat. And we have 3 different types of medications to actually treat opioid use disorder. This grouping of medications is typically called MAT, or medication-assisted treatment. The newer terminology for it is MOUD, or medications for opioid use disorder. So regardless of the terminology, when somebody either says MAT or MOUD, you're talking about 3 different forms of medication. Those being buprenorphine, also known as Suboxone or Subutex, methadone, and naltrexone. So all 3 of these medications, they're going to work on the opioid receptors in our brain a little bit differently, but really the 2 main takeaways in basically what these drugs are going to be able to do is they're going to be able to relieve a patient of those withdrawal symptoms when they do abstain from use. And they're also going to reduce cravings for that patient. So as you can see here, we've kind of laid out the different types of medication and the differences between all of them. I wanted to point out one difference between methadone and buprenorphine that I think is particularly important and really a good thing for everybody to think about. And that's how you actually obtain the medication. So first we'll start out with methadone. It's a very controlled substance. And in order for somebody to use methadone as a treatment option for opiate use disorder, they themselves need to be enrolled in a methadone treatment program. And what this means is that they need to show up every single day to the clinic or to the treatment program that they're enrolled in to take their dose in a supervised setting. So it's a very, very structured program. They have to show up to a doctor's office every single day. So if you kind of take a step back and think about your own life, think about what kind of obligations you have on a day-to-day basis. You probably have a job, you might be going to school, you probably have some family obligations at home. Think about if going to the doctor's office at 10 o'clock every single day in order to get a dose of medication would work for you. You know, would your boss let you leave your job at 10 o'clock every day? So this could be a little bit difficult for patients, and it could be difficult for them to kind of lead an everyday, quote unquote, normal life. And then on the contrary, buprenorphine or Suboxone is a little bit different. So you do not have to go every day in person in order to take your dose in a supervised setting. Instead, your doctor or prescriber can simply prescribe the medication to the pharmacy, and you can go pick it up just as you would any other form of medication. So this is kind of why buprenorphine and Suboxone has been more of the preferred treatment option for a lot of patients over the past few years. So I think that's just a pretty interesting difference to kind of think about in your own life on, you know, which form of medication is the best for a specific patient. But kind of on the contrary, for methadone, sometimes that structure that's involved can be very beneficial for that patient, and they can actually benefit from the accountability involved in showing up to the doctor's office every day. So there's some differences between the three different types of medications. Ultimately, the patient is going to have that conversation with their provider and determine which form of treatment is going to be the most beneficial for that patient. So again, we pretty much talked about this, but the main benefits of medication-assisted treatment is going to be that it helps manage the actual physical symptoms of withdrawal. So it'll relieve the patient of those withdrawal symptoms. It'll also reduce any cravings that the patient might have to use opioids.
All right, so kind of switching gears here, talking about New York Matters and kind of what Keely and I do. So in conjunction with the New York State Department of Health, we have been able to create an electronic referral platform, which we'll talk about, and then embedded into that platform, we have a few voucher programs. So we have a medication voucher program and a transportation voucher program. So we quickly realized that working with this patient population, there's several barriers. And so our medication voucher program allows patients with Medicaid or no insurance to receive up to a 14-day prescription of buprenorphine. And that kind of serves as a bridge script until the patient is linked to an outpatient treatment clinic. And then our transportation voucher program, we have partnered with Uber Health to provide patients with round trip transportation to and from their first clinic appointment.
So when the New York Matters program started, there were really three primary points of focus. The first being prescribing and optimizing opioid prescribing that's happening in emergency departments. So the New York Matters program started with referrals coming out of emergency departments because that is the location where a lot of patients with opiate use disorder might present and be ready for treatment. So we wanted to optimize the opioid prescribing actually happening in the EDs and ensure that only patients who really require the use of opioids are getting them. Secondly, and kind of at the same time, we wanted to optimize access to medication-assisted treatment in the emergency department itself. So after an overdose, or if a patient presents to the emergency department in acute withdrawal, We wanted to be able to offer them medication-assisted treatment in the ED to relieve them of their withdrawal symptoms, and specifically increasing access to buprenorphine in the ED setting. Lastly, referrals. This is really where the New York Matters platform comes into play. So not only did we want to give them access to medication, we wanted to be able to link them to long-term treatment. And we wanted to be able to develop a very efficient system to do just that. So we'll talk a little bit more about the logistics of the actual platform and the referral platform.
So the referral platform is housed on the New York State Health Commerce System and can be easily accessed on any electronic device. So we do provide iPads to all of our hospital partners that are interested, but it can be accessed on a phone, a computer, a desktop, and we really encourage patient engagement as well when completing the referral process to treatment. And so as Kaylee mentioned, when New York Matters started, referrals primarily came from the emergency department. And although those are still where a bulk of our referrals come from, we quickly realized that the referral platform is very applicable to several different settings. So we have partnered with correctional facilities, other EMS agencies, inpatient referrals, telemedicine, and basically, again, we serve as kind of the middleman facilitating linkage to outpatient MAT clinics. So this map shows our current and future partners across New York State. So New York Matters is a statewide program. It started in Buffalo and then continued to expand across the state. So the black icons with the H are current hospital partners. The yellow icons with the H are future hospital partners. So partners we've been in communication with, and hopefully they'll be coming on board shortly. The kind of red icons are all of our correctional and law enforcement partners, and then the blue icons are all of our current clinic partners across the state. Alrighty, so that kind of wraps up our presentation here this afternoon, and we're certainly happy to open it up for any questions or discussion.
Thank you. That was great information. I welcome questions. You can unmute, you can put it in the chat for the Q&A. No questions? I think that this is a great program. I feel like this is educational for me because I was not familiar with New York Matters until just the last few months since I've been working with Western New York R-AHEC. And maybe how many individuals do you usually connect with, I guess, in a year, or like how many people do you usually end up helping?
Yeah, so I would say it's pretty variable. So the program started here in Western New York, and it really started with the emergency department. So linking patients from Western New York ERs to outpatient MAT clinics. But over the past probably almost 2 years now, or maybe a year and a half, we started to expand the program outside of just Western New York and across the state. So over the past 3 months or so, we've been in the process of hiring and onboarding regional care coordinators all across the state. So there is a total of 8 of them who are currently hired, and their job is to expand the program in their specific home region. So that number of referrals, to go back to your question of how many patients are served each month, has really been steadily increasing as we started to increase the number of referral sites across the state. So to be completely honest, I do not know the number off the top of my head, but I guess that's kind of increasing month to month, and hopefully soon we'll be able to share some data on that as to where all the referrals are coming from.
Thank you. Does anyone else have any questions? Okay. If not, we will move into the second part of the webinar. Dawn Stone will be doing a Narcan training with us. So Dawn Stone is a peer recovery advocate at Spectrum Health and Human Services here in Worcester, New York. She's been working with Spectrum for 4 years. Before Spectrum, she was a family development specialist for Early Head Start for about 19 years. And Dawn enjoys sharing her story and advocating for people just like herself with mental health and addiction diagnosis. And Dawn has done numerous Narcan trainings for us at Western New York Rural AHEC. So I will pass it over to Dawn now.
Hi, thank you, Erin. Good morning. I'm really excited to be doing this training. The more people that are trained with Narcan, hopefully the more people we can save. I loved hearing all the different statistics from the state. I myself work in a small county, but we have had a lot of overdoses and a lot of people have passed from overdoses, but we've had a lot of people saved too. So that's one of the reasons I'm so adamant about people getting trained on how to use Narcan. So I am really excited to be here today and be doing a training for everyone. I do have a couple of videos, so I'm going to share my screen. So I can play the first one, talks about the stigma as far as using Narcan. Some people think, well, you know, how many times should you try to save someone who is addicted to opiates? But is there a number? You can't really put a number on how many times you would try to save someone who was having heart attacks or was diabetic or just having health problems. So it's right along the same lines. People, you know, hopefully will understand that this is as important in helping people with any other health problem. And it is called harm reduction. And that's what this video will talk about is, can you, I might need help sharing my screen. So it will help us understand with harm reduction that it may take 4 or 5 times for someone to overdose before they're able to get the help that helps them to not, there we go. To be able to stop using opiates. So, all right, I will start the videos. Can you see my screen okay?
Yep.
Okay.
Today, I want to talk about Narcan. Narcan is an opioid reversing drug. So it has the capability to save the life of somebody who is experiencing an overdose on opioids of any type, be that prescription or non-prescription. Okay, so why do we need Narcan, right? That's the question. It's an opioid reversing drug. So 130 people die a day from opioid related deaths in the US. That equates to 47,600 people a year losing their life to opioid fatalities. Here's a chart just detailing the number of deaths involving any opioid by year, right? So we start in 1999, it's really low, and it goes up and up and up, and this data ends in 2017. This chart just shows us that there's different types of opioids, right? So you have commonly prescribed opioids, your Vicodin, your morphine, etc. You have heroin, which is generally purchased on the street, and then you have other synthetic opioids, most notably fentanyl. This is Katie. She lives in Western New York. She's a mother, a worker, a volunteer. She goes to grad school for wildlife conservation. And she was revived by Narcan 17 years ago. Narcan matters because it saved Katie's life. There's sometimes controversy around harm reduction tactics when we're talking about stigmatized subjects within society. So anything that could be considered taboo, like drug use or sex. Harm reduction focuses on reducing the harm associated with a specific behavior. And I can assure you that each of you have practiced harm reduction today. Both wearing a cloth mask and wearing your seatbelt are examples of harm reduction. So a cloth mask seeks to mediate the risks of going out in public during a global pandemic. And a seatbelt seeks to mediate the risks associated with driving, because driving is an inherently dangerous behavior. The goal of Narcan is to help people stay alive long enough to live beautiful lives. This is pretty much the same goal as masks and seatbelts. But still, the internet can be a scary place and a harsh place, right? And I oftentimes see things there that question the use of Narcan or question the worth of the lives that Narcan saves. It's interesting because I never hear those same sort of conversations around people who have had heart attacks and need to be revived. And the truth is that stigma impacts the kind of help that people get and also how society sees them. Which I can say as a person who is in recovery, when I was in active use, I didn't feel real good about myself. Katie's life is worth it. And it could have been you. It very well could be you who is in a situation where Narcan is needed.
So, as I said, thank you very much for wanting to be trained in Narcan. And it is so important to help people not only with their diagnosis, but as she said, harm reduction, get them to a point where they can get healthy. So now I am going to show you the Narcan use video. Now, Narcan is a trademark. So naloxone is the name of the actual medication that we use to stop someone that's having an overdose. So this shows you what to do when you come upon a person who could possibly be overdosing. And then I will go through like all the different things you've seen on here. So let's see.
Narcan nasal spray is an emergency treatment for a known or suspected opioid overdose. The appropriate use of Narcan nasal spray can help you save a life. Narcan nasal spray is not a substitute for emergency medical care. As with any drug, you need to be aware of important safety information concerning its use. If you encounter someone who is unresponsive and you suspect an overdose, first shake their shoulders and shout their name. Kevin. Ask if he or she is okay.
Hey, can you hear me?
Check for signs of an overdose, unresponsive to touch or voice. Breathing is slow, uneven, or has stopped. Snoring, gasping, or gurgling sounds. Fingernails or lips are blue or purple. Administer Narcan nasal spray as quickly as possible if someone is unresponsive and an opioid overdose is suspected, even when in doubt, because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication, seek emergency help right away. Narcan nasal spray is not a substitute for emergency medical care.
I'm with somebody who stopped breathing. I think they've had an overdose.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position. Continue to watch the person closely. If they do not wake up or respond to your voice or touch, or if they do not seem to be breathing normally within 2 to 3 minutes, use a new Narcan nasal spray to give an additional dose in the other nostril. Acute opiate withdrawal symptoms may occur from use of Narcan nasal spray in patients who are opioid dependent. Symptoms include body aches, diarrhea, increased heart rate or tachycardia, fever, runny nose, sneezing, goosebumps, also known as piloerection, sweating, yawning, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, abdominal cramps, weakness, and increased blood pressure. When the emergency is over, put the Narcan nasal spray back in its box and throw it away in a place that is away from the reach of children.
Okay. So that showed you in a quick few minutes there of what to do if you come upon somebody that is overdosing. So the first thing I want to say, if you give Narcan naloxone to someone who is not overdosing, this is not going to hurt them. That one of the side effects could be an increased heart rate, but if someone is already, say, having a heart attack, then their heart is already out of rhythm, so it's really not going to hurt them. If you come across somebody you're not sure why they're unconscious and say that they have passed out from alcohol abuse, had drank a lot of alcohol or used a different drug other than an opiate, it's just not going to work. It's basically just trying your best to hopefully help a person that you're not sure what's going on with them. So as the ad or the video said, you'll get a kit. It has 2 of these little Narcan nasal sprays in, and you open the packet, and the first thing is you get a little guide, which is nice when you have a Narcan kit, which you can get at any of your pharmacies. We could send you one if you give us your email address or address. The other thing is you can get them at your health department for free. So right here you have a nice little packet that will show you exactly what you're doing. So say you think you forgot how to, I could probably stop sharing my screen too. You're not sure what you're gonna do with the Narcan nasal spray, there's directions right there. Some of the kits even have a little yellow card. Let me see if I could stop sharing my screen. They have a little yellow card that comes in it, and that also gives you the directions. So you immediately want to try to wake the person. If they won't respond to you, you suspect that this might be happening to them, then you take the little Narcan spray and you insert it into one nostril and spray it. Don't spray it, pre-spray it, because as I said, there's not a lot of medication in here. So if you squirt ahead of time, you're going to squirt out all the medication. It only takes a couple seconds to squirt this in one nostril. Then if they don't wake up, you take your second one, and within 2 to 5 minutes, you try it in the other nostril. Reposition their head, just like if you were giving them CPR. Sometimes, just like with CPR, sometimes your first breath doesn't get in. Well, sometimes the first shot of Narcan or naloxone might not go in. So after you've given the 2, if the person wakes up, they may be anxious. They may say, what's going on? They may not even at first believe that they were overdosing, but if they're not breathing, they're blue, you can assure them that they were overdosing and they were not breathing, and they were very much unconscious or on the verge of death. So you calm the person down. You've already hopefully called 911. You want to do that right when you first get on the scene. You call 911, and then you talk to them about talking to a medical professional, maybe even going to the ER with you. So as it said on the film, how to recognize an overdose. Well, they're unconscious, they're swallowing, they're not breathing, or breathing is very noisy and labored. they're turning blue, and the person does not respond to you, even with shaking their shoulder or doing a sternal rub. What to do in case of an overdose, we'll go over the steps again. You call 911. You administer the naloxone. The naloxone will block the heroin or the opioid for 30 to 90 minutes, reversing an overdose and causing withdrawal, after which the overdose may come back. If no response, give the second dose in 2 to 5 minutes. And obviously no response from there, then you're going to want to do some rescue breaths and see if they go in. You administer the naloxone by making sure the person is on their back with their head tilted back, and spray in one nostril or the other one, the full spray. If the person is not breathing after you've done the 2 shots of naloxone, you do rescue breathing. Your kits will come with a rescue mask that you can put over the person's mouth so that you can give them rescue breaths. And it also comes with alcohol prep pads that you can wipe their mouth off with. If they're still not breathing, they don't wake up, they continue doing rescue breathing or start CPR. Place person in the recovery position if they are awake but not fully awake, or if you have to leave them to call 911. Fortunately, we usually all have cell phones now, so it's much easier if most people have a phone right on them. So afterwards, like I said, you explain what happened. Definitely advise against using any more drugs or leaving the scene and waiting for EMS to arrive. If the person refuses EMS or to go to the nearest emergency room, try to stay with the person until after the Narcan is fully worn off, at least 3 hours, in order to watch for return of an overdose. So I really impressed that upon you. I lost a family member that way, that they had Narcan happen or used on them, and they insisted they were fine. And the next morning they were found and they had passed from the overdose returning. It is legal to carry and use naloxone in New York State if you're properly trained. Not all pharmacies give it out, but if you tell them that you are trained, they will give you a kit. If you go there and tell them your kit has expired, because they do expire after 2 years, they will give you a new kit. If you go in and tell them that you have used your kit, they will give you a new kit. There is paperwork that you can get from the health department that talks about to send into the state if you use the kit, and so that they have that information. So you return your kit from wherever you got it if it is expired, or if you, as I said, if you have used it. So some risk factors for people overdosing. It doesn't have to be, oh, they only use heroin. They also might be mixing classes of drugs. So they might be using cocaine, but it actually ended up with fentanyl in it, which is the most common cause for overdoses. Or if they're drinking and someone gave them something and they don't know what it is, but it happened to have fentanyl, and they could also overdose. So using, as I said before, does not hurt them if you use the Narcan kit on them. Also reduce tolerance. So if somebody's been incarcerated in the hospital or haven't used it in a few months because they've been in rehab and they start using again, they think they're going to use the same amount that they used before they stopped, and that can cause them to go into an overdose. So the Good Samaritan Law applies just like it does if you do CPR or first aid on a person. If a person who in good faith seeks care for himself or someone experience a life-threatening emergency will not be charged or prosecuted for a drug or alcohol-related offense, including possession of drugs, with some exceptions. So if someone is using drugs with the person and they use Narcan on them and then the police arrive, they will be offered protection from charges and prosecution to a limit. It does not count if there's other crimes on the scene, such as weapons, stolen goods, parole violations, or if CPS is called. So, but mostly if someone calls and they save a life, whether there's charges that can happen or somebody else might get in trouble for providing the drugs, just knowing that you have saved that person's life really should count. And if you're a citizen walking down the street and you administer Narcan and you save someone from an overdose, I would hope, that anybody would do that, no matter if it was someone they knew, didn't know, a loved one. So we hand out, a lot of times when I do the training, I hand out a pre and a post survey to see if you've learned anything. So I'm going to go over the questions. When you first come across someone who has overdosed, you should A, administer Narcan, B, call 911, C, do rescue breaths, or D, do nothing. So when you come across someone who has overdosed, you right away want to call 911 because there is a chance it's not an overdose. It could be a heart attack. It could be anything. But also if it is an overdose, they still need to be seen by a medical professional to talk to them about the fact that Narcan can wear off and they can re-overdose. Narcan reverses overdoses due to A, benzophenorphines, cocaine, opioids, all of the above. Well, it is opioids and Narcan, but as I said before, fentanyl can be mixed in with cocaine or any other drug, but it is an opioid. Once the first dose of Narcan is administered, another dose can be given in, you should never give a second dose, 2 to 5, 5 to 10 minutes, or 30 minutes. So it's within 2 to 5 minutes. And how long after Narcan is administered can a person go back into an overdose? And this is very important. They can go back into an overdose for 90 to 120 minutes. So that's up to 3 hours. They should never be left alone. Narcan does expire in 2 years. It is legal to carry and use Narcan in New York State if you're trained. And Narcan cannot be stored anywhere. You should not leave it in your car throughout summer and winter when it can freeze, but it's pretty safe. So you can use it, have it in your car most of the time. But yeah, you don't want to let it freeze. You don't want to let it get too hot. And when should it be necessary for an individual who has experienced an opioid overdose to receive follow-up care? And follow-up care is always, always necessary. So do we have any questions?
So we have a question. I work from an individual. I work in a community pharmacy and many doctors prescribe Narcan along with a patient's opioid prescription. However, many times the patient doesn't want the Narcan and refuses to pick it up. Do you have any tips on how to convince patients of the importance of having Narcan at home?
Sure. Well, let them know that even if they don't overdose, if they're around people that are using or come across someone and they don't know what's wrong, Narcan is used like a first aid, should be in everybody's first aid kit. And maybe they would take it that way by not saying, well, just in case you do, maybe if you take the blame, not the blame, but the fact that it might, even though it might be used for them, at some point it could be used for a friend or someone, a loved one that might accidentally overdose on opioids.
Eva, thank you for the training.
You're welcome.
Is there any other questions? Thank you, Dawn. And from my understanding, we should be sending kits to everyone who participated today. I have contact information. I'll make sure I have addresses so that we can send a kit to everyone that participated today. Thank you, Dawn, again for the training. So next week, we will have our last webinar next week at 12 with Davina Moss-King. She's going to be talking about substance abuse in women and pregnancy, along with implicit bias. So you're welcome to join in next week if you were able to join.